Well, thank you very much for the invitation. It's a pleasure to see you guys and look that you all are well in those times we are facing. I would like and I would love to be with you this year. It was not possible, and maybe next year we'll be together again, and all that mess will be all right again. My talk is about transcranial motor evoked potentials recorded from cranial nerve innervated muscles. So the most known motor evoked potentials we are used with is the facial nerve. So the majority of the time I will talk about the facial nerve monitoring with corticobulbar evoked potentials. After this lecture, the attendees must be able to understand the theory behind the corticobulbar technique and the practical features to record the transcranial motor evoked potentials and of some cranial nerve innervated muscles. My disclosures, and well, I divided for practical purpose the lecture in standard of care for cranial nerve monitoring techniques, that is the triggered EMG and continuous EMG, and the techniques beyond the standard of care, because in many countries they are not used to do transcranial motor evoked potential for cranial nerves. So I consider that beyond the standard of care. And there is another group of techniques, the cranial reflex, that we can consider beyond of the standard of care, but is not the issue of my talk. Everybody knows that the A-train at the EMG, at the continuous EMG, is the most reliable technique we use, the most simple and reliable technique we use to monitor facial nerve and cranial nerves in the OR. It is a sinusoidal symmetrical sequence of high frequency and low amplitude signals. There are types of A-trains that can occur continuously or in bursts, or a combination of both. And the most accepted criteria for bad outcome is the A-train time. A-train time is the quantity, is the amount of A-train we have in the surgery. So usually it is obtained after the surgery, and we need something that goes during the surgery. Even doing that during the surgery, A-trains commonly appear during the cranial nerve surgeries in a high, and the technique is with a high sensibility but a low specificity. And the positive predictive value of this technique is around 50 to 60%. So we have a lot of discharges that don't correlate with facial nerve bad outcome. And the value, the positive predictive value of transcranial motor evoked potential is almost the same of the EMG, the continuous EMG. So why not use that? These work well for facial nerve and is being studied more and more for facial nerve, but in the other cranial nerves, is it the same? Can we consider the same for continuous EMG? It is controversial, but because we have, in many cases, in many surgeries, we see a lot of discharge. There are types of A-trains, and some authors consider that even when we have a lot of discharge, the behavior is not the same for cranial nerve and other cranial and facial nerve. So compared to the facial nerve, they look the same, but do they have the same behavior? Until that moment, the results are controversial. in the literature, missing correlation between EMG activity and clinical outcome for EMG of other cranial nerves than facial nerves. Another technique that is considered the gold standard for facial nerve monitoring is used to localize the nerve. So if you have some doubts about where is the nerve, you can stimulate with a probe, monopolar probe or a bipolar probe at the structure you think is the nerve. And you can localize, evoking a CMAP, a compound muscle action potential. And we will see the distance according to the intensity of stimulation we are using here. We are using 1.4 milliamps, so we are close to the nerve, and we have this potential. We use constant current and not constant voltage stimulation, but the technique is surgeon dependent. So I have to stop the surgery and ask him to stimulate the nerve. So if you have a discharge, an A train, you have to ask the surgeon to stop the surgery and try to localize and to stimulate the nerve to see what's going on. So here we not consider this technique as a monitoring. We are not monitoring, we're stopping the surgery and stimulating to localize the nerve and to see if the amplitude of the CMAP is the same, is normal or not. The advantage of transcranial motor evoked potential is that we can stimulate without the cooperation of the surgeon. We have to take care because we know that in some case we stimulate with high intensity stimulation, evoke some movement, and it can disturb the surgeon. So you have to ask him a little pause or to advise him that you do a stimulation and ask for, okay, you can do that. The technique uses a single pulse. The first report of intraoperative monitoring is described here by Dong, and they published it with other colleagues, with other known colleagues, and adopting the concept that only a train of stimuli can evoke a central response. If we use a single pulse, we cannot evoke a central response, but we can evoke a peripheral response. So to evoke a central response, we have to summate temporally and spatially the pulses to evoke through the corticobulbar tract the CMAP, the compound muscle action potential. Adopting that concept in anesthetized patients, we use a train of stimuli to evoke a facial nerve or the cranial nerve motor evoked potential. So they combine a single train with a pulse of train to show that with a single train, with the same intensity, we have no response, and with the same intensity using a train of stimuli, you have the response. So we are seeing a central response and not a peripheral one. Other authors using the same technique decided to do a double stimulation like this. A train of stimulation as the stim 1 and a single pulse as a stim 2. And they published that in 2007, Dr. McDonald, the stimulation assembly used the C3, M3, or C4, M4, depends on the side you want to see the response as a node, and the CZ or MZ as a cathode. The stimuli is two linked stimuli repeated at 1 to 2 hertz. You have to do this continuously to facilitate the response. First, a train of 4 with 0.2 to 0.5 milliseconds pulse duration and 1 to 2 milliseconds interstimulus interval. I use 2 milliseconds here. The second is a single pulse with the same duration and the same intensity that will be done 50 to 90 milliseconds after the first stimuli. Recording orbicularis ori or mentalis with needles or hooked wires is much better being done with coated needles or with Teflon coated needles or monopolar coated needles or hooked wires, because we avoid the crosstalk between other muscles. The major advantage is a minimal or no movement and surgeon independent. Here is one of my recordings. We can see the artifact during the EMG, the continuous EMG. We will see the stimulus artifact. And here is the stimulus artifact with the response, the central response. And with a single pulse, we have nothing. In this case, I'm using here constant voltage constant here. And as I lost the response here, I increased a lot the intensity of the stimuli, and I have a response here. You will see that this response is short in latency. There is a short latency response here. I use almost twice the intensity I need at the beginning of the surgery. And also with a single pulse and the same intensity, I have a response here. So this is not a central response. This is a peripheral response. I know that because I have the response here with a single pulse, and I have the same response with a train of pulse with much intensity. So when I go down again, the central response disappears and the peripheral response disappears. This patient outcome was not good. It was a grade 5 Hausbracken, grade 5. In a paper published in 2015, Javier Urriza and colleagues raised the doubt about the central region of the corticobulbar MEP. They showed in the median nerve, they simulate the median nerve with threshold, with some sub-threshold. They found the threshold of the stimuli. How can we do this? We increase the intensity of the stimuli progressively, and we will see when the CMAP will appear in the median nerve. It's a peripheral response. After that, I will decrease the stimuli from about 10%, 20%, the threshold, and I have nothing here with a single pulse. But using this sub-threshold intensity, I will do a second pulse, I will do 3 pulse, I'm sorry. I will do 4 and 5, and I will see a CMAP originating here. So even using sub-threshold stimuli, I can evoke CMAP using more and more pulses. So we have to take care. Other authors from the same group refined the technique. Dr. Fernandes Conejero from Barcelona, we had the chance to talk about this. And she told me that, and published this, that the best option is to do the single pulse first and then the train of pulse 90 milliseconds after, because we will avoid the facilitation of the train of pulse in the peripheral response. And so I'm using this technique now. So I do the first simulation is a single pulse, and then I do a train of pulses with the same parameters I described minutes behind. And we will see the central response much better. Some Brazilian people do a paper, right, published this paper, suggesting that the best placement for the electrode, the anode, is C5 or C6, because it will be closer to the facial area, motor area, than the C3, C4 that is near the hand area. And they published this paper suggesting this new paradigm. Another group of Brazilian guys, together with some guys from Germany, did a systematic review of facial nerve monitoring. And they stated that there is a lot of things that must be improved. They concluded that despite there is a general agreement of the satisfactory functional prediction of the techniques, there is a lack of standardization in the paradigms of simulation and recording. So authors use it to do this in a different way. So we don't know if we are comparing the same thing. Maybe we are comparing things that are different. For transcranial motor evoked potential, we use the warning criteria for warning the surgeon is 50 to 65% the drop in the amplitude of the facial transcranial map. We know that the transcranial map varies during the time, and there is not too much for the facial nerve, but 50 to 65% drop can occur even doing the surgery without any event. So we have to pay attention in the surgery and correlate what's going on in the intraoperative monitoring and the surgery. Dr. Deliris also published his results using the same paradigm for the vocalis muscles, so putting electrodes in the vocal cord, and also 2 years later for the cricothyroid muscle is a more extrinsic muscle of the larynx, so it's much easier to put the electrode there. This is the way I use to do. We use needles with a Teflon coat needles or hooked wire. Hooked wire here in Brazil are very expensive, so we cannot use them. We use monopolar needles in pairs. Here is for the 7 superiors, for the 7 inferior, and then for the 10th for the vagus nerve. So the vagus nerve I use the electrodes in the midline oriented to the vocalis muscle. We can use this with an electrode of 13 millimeter in a thin guy, or you can use a longer one with 2 millimeters for someone more huge. And the accessory nerve, and then the tongue for the hypoglossus. The stimulation paradigm I use is was described. We can use the C4. Here is the C4 or C6 with CZ0. The anode will be at the convexity, and then at the 0 will be the cathode. So I used to put both electrodes, and I choose the best assembly. I decide at the time which is the better response without the peripheral response. Using this stimulation protocol is here. The assembly is using C3, C5, or C4, C6. We can use this bilateral like this for posterior fossa tumor. If it is schwannoma is lateralized, I can choose to monitor just one side. But if it is in the midline, is a tumor in the midline, I can choose for both sides to be monitored. The stimuli should be linked, so the same intensity I use for the single pulse should be the same for the train of pulse. First, I use a single pulse of 0.2 to 0.5 milliseconds, and the second is a train of 4 to 5 pulses of 0.2 to 0.5 milliseconds duration. And the intensity I will choose knowing the the threshold. So I will increase the stimulation until I have the peripheral response. If I have the peripheral response, I have to reduce it, and I will know that this is the threshold. I cannot pass this intensity. And I use a 30% of this intensity to obtain my response, my central response. Well, this slide is just to show you that we can trust the technique, because this patient is a patient that already did the surgery in the past, and the outcome was a light facial palsy. So during the clinical evaluation, we can see the patient has a facial palsy. So the latency is prolonged compared to the other nerves, like hypoglossus and accessory and vagus. Latencies are much shorter than the facial nerve and should be almost the same, a little bit longer for the other bulbar nerves than for the facial. So the response should be here, and it is prolonged here, maybe because of the facial palsy. And we can see this is consistent also for facial, vagus nerve, accessory nerve, and hypoglossus. I will describe 3 cases. I think it is interesting for you to see the importance of this technique. In this case, the female with 43-year-old with T4B cerebellopontine angle tumor, left 8 nerve Schwann cell tumor that complains of dizziness, hearing loss, no signs or symptoms of other cranial nerve involvement. And here we can see the A train up here, and the corticobulbar map, and the facial of the facial and vagus nerve. Facial here and the vagus nerve here, a train, and the pulse. At that time, I was using train and pulse. It is before I changed for the pulse and train. The orbicularis oculi motor evoked potential used to have a lot of stimulus artifacts, so I'm using just the low face. So the orbicularis oculi here, and I took out the facial upper face from the recording because of the stimulus artifact. And here, the accessory nerve is being monitored together with the arm and leg, because it causes a lot of movement of the shoulder. So it disturbs a lot the surgeon, and I asked him to do a motor evoked potential of the forelimbs, and also with the accessory nerve separated from the facial one. You will see that sometimes we have thresholds that are different for one cranial nerve and other. And to have a vagus nerve good response, I have to use sometimes much more intensity than needed for facial one. So it will cause movement. And the surgeon is interested in the facial nerve, so I will reduce the intensity. I will lose the vagus nerve response, but I will have the facial nerve monitoring consistently. I warned the surgeon here that we have a discharge of the facial nerve. We also have here in the accessory nerve, but the amplitude of the motor evoked potential still is good. After some minutes of another A train here of the facial nerve, I saw that the motor evoked potential dropped a little bit, but the vagus nerve was okay. And the cranial, the other forelimbs and accessory nerve was okay too. So I again said to the surgeon to stop and do some saline solution and wait a little bit. And after that, they start again the surgeon and a lot of discharge again. And I saw this drop progress from 50% to 65%. And I had to increase the stimuli. And I told him, you have to, we have a lesion of the facial nerve, the amplitude of the motor evoked potential dropped more than 50%. and I had to increase the intensity to obtain that. But the surgeon goes and said to me that the patient did radiotherapy in advance, and they told us the patient that it could occur that it was not able to resect the nerve, and he decided to cut it and to do anastomosis in a second time. So it was a bad outcome for this patient. I cannot expect something different from that. We lost all the response here, but we still have the vagus nerve response. This is to show you that what we are seeing correlates with the clinical outcome. The second case is a male, 38-year-old with a T3A CPA tumor. Is a tumor that is big, but it's just in contact with the brainstem. Also, Schwann cell tumor, and the patient complains of dizziness, partial hearing loss, no signs or symptoms of other cranial nerve involvement. And this video will show you that we can do motor evoked potentials of facial nerve without disturbing the surgeon if you take care of this. I'll put the sound here. But the surgeon is doing the surgery here, and I will enable the stimulation, and I will do the stimulation here. I'm using a single node, but I'm using isolated stimulation. I do stimulation, and I do it again, and there is no movement in the field. So I can do this more frequently without disturbing the surgeon. Sometimes we see just the pulse of liquor, and there is nothing more than that. So we can titrate the intensity of the stimuli to do this continuously. After that, I decided to start doing the technique stimulating continuously, and that I will show you in this next case, is the last case, that we can do this continuously without disturbing the surgeon. Is a female, a 9-year-old ependymoma attached to the fourth ventricle. This is the image. Ataxia and loss of balance was the main complaint. No other sign or symptom of cranial nerve involvement. And the first video, we'll see that we have the EMG here. I'll start the EMG in a few seconds, but I'm doing this continuously with 7.1 constant current milliamps at the left side and 6.4 milliamps at the right side. I have no peripheral response. I just have a central response. Here is the here with this artifact is the upper facial nerve, and the lower facial nerve is the other. Here's the stack. We can see the central response here. There is no response, peripheral response for the up and lower facial territories. In this other video, I had the lucky of doing this to detect a discharge during the resection, and immediately after this discharge, I lost the motor evoked potential. So it was almost in the end of the resection, and I forgot to start the continuous EMG at that point. And what I saw is that the response was very small in the right side, and there is no response in the left side. Was not constant. Sometimes I have the response at the right side and no response at the left side. And I decided to increase the intensity of the stimulation. It's still 70, but I will increase the response. Here, it's not constant, the response. Sometimes I have, sometimes not. And I don't have the response here. So I decided to increase. Increasing the intensity and frequency of stimulation. I increase it to 2 Hertz to facilitate the response. So I'm using here same milliamps, and I have the response much more constant here, and not that constant in the left side. And by the end of the surgery, the patient showed the response on both sides. You'll see this more and more frequent here, but we still don't have a peripheral response, so I'm confident that this is a central one. There is integrity of the facial nerve and the facial corticobulbar tract. And at the end of the surgery, I had the response and the patient awake without any depth. Okay. My final remarks is that the technique is feasible and useful in the majority of patients. Standardization of corticobulbar motor evoked potential techniques is desirable, especially the type of recording needle. If we use the common monopolar needle we are used to do, we can see some cross-talking, so we can lose the vagus nerve response, for example, and we still have some MEP, and the MEP maybe is the facial of the platysmal muscle. So the need for monopolar electrode is because of the cross-talking. The point of recording, Dr. Conejero suggests that we stimulate the facial nerve before the surgery to localize where we will see the best twitching, the best response, and where we have the best response is the best place to put the electrodes. The stimulation assembly and the different techniques and their combination should be also tested, looking for the best outcome. Maybe using EMG, continuous EMG, transcranial MEP, and reflex will have a huge number of techniques to protect the outcome. And multi-center studies should be incentivized too, because what means is that if I have a technique that works for me, but is just working for me, I don't know if it is trustful enough to be used in all other intraoperative monitoring services. This is my my last slide. If you have any question, I'll be happy to answer. This is my email. You can email me. I like very much to be in touch with you guys from Russia. Thank you very much.
Thank you very much, Paulo, and I'm happy to see you. By the way, and I hope that we will see next June in Moscow, not virtually. We have some questions, but I will ask what is the better way to ask in English or in Russian. Владислав Борисович, как лучше задать по-русски и что переводчик перевел? Как вот это правильно сделать?
Thank you very much, Paulo.
Okay.
It was very, very, very interesting and very, how to say this, applied report, not very fundamental, but very, very, very clinical centered. So I think we have some questions to you. Our colleagues have some questions. I guess Dr. Sinkin.
Владислав Борисович, я, видимо, не в тот канал говорил. Вопрос такой, как лучше задать по-русски, и переводчик переведет, чтобы у нас не потерялось ничего при записи. Не совсем понятно. Paulo, do you hear me?
If they want to ask in Russian, she can translate to me. It's okay for me. I don't understand Russian. Sorry. Just спасибо.
Okay. So now.
Yes, I think.
Okay. Well, I will ask in Russian, and the interpreter will translate. Итак, у нас есть вопрос один вопрос от Николая Бобрякова, нашего коллеги, большого активиста интероперационного нейрофизиологического мониторинга. Я думаю, вы с ним виделись на конференции в Москве. Николай спрашивает, есть ли у вас опыт кортикобульбарных транскраниальных MEP при регистрации с прямой, забыл по-русски, musculus rectus lateralis, отводящего нерва. И какие параметры регистрации и стимуляции вы используете в этом случае? Okay, is it clear?
It's an interesting question, and I can say this is a challenge to monitor the extraocular muscle with this technique, because as closer you are from the anode for the stimulation electrode, the higher will be the artifact, the stimulus artifact. So even changing the low filter or the high pass filter to avoid these artifacts, the response is not as stressful for me. Every time I tried to do this with extraocular muscles, increasing the intensity, I saw peripheral response. So the intensity of the stimulus from here to the nerve here is, we don't have to rise too much to have an artifact in the peripheral response. So this is a problem of the technique, I think. This is one of the reasons I avoid to use the facial nerve too in the upper face. I also record, but sometimes it's not useful to use this. I think it is much useful to use the lower.
Окей, thank you, спасибо. Еще у меня есть вопрос. Как вы думаете, 50% снижения амплитуды, этого достаточно, чтобы сказать достаточно точно о том, что есть признаки повреждения? Потому что когда мы проводим кортикоспинальную стимуляцию, мы, мой экспириенс, мой опыт, мы используем принцип «все или ничего», то есть 100% падения амплитуды.
This is another good question. We cannot compare the corticobulbar with other spinal monitoring, for example. If you look at the behavior of the EMG, the continuous EMG for spinal monitoring and for cranial nerve monitoring, you see a lot of differences. Like EMG for root, like a C5 root or C6 root, we will see a discharge, and sometimes the patient awake with nothing. And we will see during the surgery a lot of discharge, and there is no bad outcome. Okay. For facial nerve, sometimes we see small discharge, and the patient awake with small facial palsy. For other cranial nerves, I used to see a lot of discharge and the patient awake with nothing. And so maybe the behavior between those nerves are different, first of all. I agree with you that 50% seems to be a problem. Maybe we will warn the surgeon much more than needed, because there is a variation of the amplitude of the response. So from one trial to the others, I saw you continuously doing that, the amplitude drop and grows and drop and grows continuously. So if we measure that, we will see that sometimes we will cross 50% and it's okay. So there is the reason, I think, that we should still work and do much more research on the technique to trying to look for the best warning criteria, for example. So for doing this, we have to have the exactly best place to put the electrode, the anode, the cathode, the recording electrodes, and so on.
Thank you very much. И в продолжении этого вопроса, если позволите, последний вопрос. В случае падения амплитуды ниже 50%, что вы просите сделать хирургов? Сколько времени, на сколько времени они останавливают процедуру? И действуют ли еще какие-то, производят ли какие-то воздействия?
This is a good question, and it depends on the surgeon. Usually, I do this with one of the best surgeons in Brazil that do cerebellopontine angle at the university, Unicamp, where I work. And he knows me, and we have a good synchrony. So when I saw something like this, I asked him to stop. And he stopped and do saline, and sometimes we use, if we have at the hospital, we use papaverine. And I asked him to stop, and he just crossed the arms and wait a little bit to see if the response improve. If he say something like, I'm not in the area of the nerve, I'm not working in this area, or I will work in another place. He will say, I will work in another place, please take care of the facial nerve, and I will work in another place. And we can do this, but always he changed the strategy of the surgery, always. If you still injure the nerve, if you see something, a discharge, or and ask the surgeon to stop, and he don't stop, and still going, he will have a lesion, irreversible one. So he must know that the nerve tolerates a little bit, but we have to give the nerve a chance. When talking to Dr. Sala, he told me that some surgeon, he crossed the arms for 30 minutes, waiting for the response to improve. And it depends on the interest of the surgeon. You want to have a good outcome, or you just want to take out the tumor. Why I'm doing intraoperative monitoring for this case, if you will not follow what we are suggesting. So we discuss and consider a lot of things to decide if you go or if we stop. But I think that we are physicians and we have the chance to discuss. We are not discussing if he is good or I'm better or not. We are just discussing which is the better in this situation for the patient.
Thank you very much, and I'm happy to see you here, and hope that we will meet face to face in next June in Moscow in our conference. So
that's really very good hope, and let's hope that all this will happen.
Okay, we have to go. We have to move.
So.
Okay. Thank you very much for the invitation. Looking forward to meet you guys.